So, a very good afternoon to everyone present here. I am Abhinav Popalia, first year MHS student in Prasanna School of Public Health, MAHE, Manipal, India. It's my honor to welcome all the participants from 25 different countries to benefit from the 11th webinar organized by Manipal Health Literacy Unit, known as MHLU, in collaboration with PGMI Chandigarh, India, and the University of Sydney, Australia, jointly organizing a free webinar on health literacy for healthcare providers, researchers, policymakers, industrial academy, and the public. Before I introduce our webinar speaker for today, I would like to make some important requests to all the participants. A small request to the distinguished participants to kindly mute their cell phones and the mic. You may post any questions during the session through the chat box. We will be addressing a few selected questions considering the time limitations. In today's webinar, we will be hearing insights from our experts on embedding health literacy research and the best practice within health services, the NSW Statewide Health Literacy Hub, and addressing health literacy need for marginalized communities. Please note each speaker will be sharing their insight for 15 minutes. Ladies and gentlemen, please allow me to introduce to our first speaker of today's webinar, Dr. Danielle Muscat, a senior research fellow at the Sydney Health Literacy Lab. Dr. Muscat's expertise in health literacy intervention for disadvantaged groups is unparalleled, making her a valuable resource in our collective efforts to address health disparities. As an advisor on health literacy to the World Health Organization and a member of International Health Literacy to the Research Standards Committee, Dr. Muscat brings a wealth of knowledge and experience. Her groundbreaking work has gained international recognition, including the Institute for Healthcare Advancement International Health Literacy Award in 2022. Today, Dr. Muscat will share insights into her research and practical strategies for improving health literacy among marginalized populations. Please join me in extending a warm virtual welcome to Dr. Danielle Muscat. Over to you, ma'am.
Thank you so much for such a kind introduction. That's really lovely. I'm just going to share my screen, and if somebody could just confirm that they can see that.
Yes, ma'am, it's visible.
Wonderful. Thank you so much. Again, thank you for the kind introduction. My name is Dr. Danielle Muscat. I am a Senior Research Fellow in the Sydney Health Literacy Lab at the University of Sydney. So we're a growing team of researchers who are keen in pursuing research in all aspects of health literacy. And I'm really pleased to talk to you about some work that we've been doing, really trying to embed health literacy research and best practice within health services. And so this is a collaboration that we have with the New South Wales health system. And so hopefully today's presentation will provide some transferable learnings that can be applied across health contexts and in different countries and contexts. Before I begin, I would like to recognise and pay my respect to the Aboriginal elders and communities, past, present and emerging, of the lands that the University of Sydney's campuses stand on. For thousands of years, they have shared and exchanged knowledges across innumerable generations for the benefit of all. So in today's presentation, I will begin by providing a brief introduction to concepts of health literacy, which I'm sure you're all well aware of, but really with a focus on organisation and systems level responses to health literacy. And this hopefully will provide the background and context to the New South Wales Statewide Health Literacy Hub, which I am jointly leading at the moment. And I'll talk to you about some of the functions of the hub and the work that we've been doing in this area. So let's begin with a kind of brief overview of health literacy, including organisations and systems level health literacy. So the definition of health literacy grounding the work that we do in the lab is the one shared on the screen. So this was a definition developed by Don Nutbeam and I and published in our recent book, Health Literacy in a Nutshell, which you can see on the screen. I think like many other kind of more recent definitions of health literacy, it grounds health literacy as being the personal competencies and organisational structures, resource and commitment which enable people to access, understand, appraise and use information and services in ways which promote and maintain good health. So that definition of health literacy was adapted by the World Health Organization definition in 2021. And what's really important and what I wanted to emphasize in my presentation today is that this definition really focuses on the fact that health literacy is determined not only by personal factors such as personal knowledge and skills, but it's also determined by organisational structures, resources, and commitment. So how well our systems, processes, and information is developed to meet the health literacy needs of the community and patients in which we serve. And I think Professors Howard Koh and Rima Rudd summed this up really nicely in their JAMA Viewpoint article, talking about the arc of health literacy, where they reflect on the fact that over the past 2 decades, the lens of health literacy has widened greatly. In addition to focusing on the needs of individual patients, the field now brings the promise of greater commitment and shared responsibility from clinicians, institutions, and care systems. The arc of health literacy bends towards population health. And so it's with that kind of arc in health literacy that we've seen these newer definitions of concepts such as organisational health literacy and health literacy responsiveness. So organisational health literacy being the degree to which organisations equitably enable individuals to find, understand and use information and services. And health literacy responsiveness referring to the provision of services, programs and information in ways that promote equitable access and engagement that meet the diverse health literacy needs and preferences of individuals, families and communities, and that support people to participate in decisions regarding their health and social well-being. And most recently, you may have seen this framework for health literate systems developed by Sorensen and colleagues, which identifies 8 action areas which support health literate systems and a system-wide response to health literacy. And I'll be drawing on this framework when I'm talking about the work of the Hub very shortly. So I hope that kind of background to the academic literature really sets the scene for the way in which I see the health literacy field changing and this kind of organisational and systems focus that has really underpinned our work in the Health Literacy Hub that I'll talk briefly about now. So what is the Health Literacy Hub? The Health Literacy Hub is an initiative that I am kind of jointly leading in Australia. It is an organisation or system response to addressing health literacy in the state of New South Wales public health system. We originally established the Health Literacy Hub back in 2018, and we wrote about this in an article published in Health Expectations that you can see on the screen. I really encourage you to read that because it gives you a kind of an introduction to the way that the hub was established. So it was established in a single local health district that was a very diverse local health district, and it had approximately 12,000 staff members and provided health care to almost 1 million residents in Sydney and New South Wales. And the hub was established as a way to address health literacy in this really diverse local health district, where we know that a number of residents had, lower levels of health literacy and there really needed to be work done to address this. So what we did was we brought together an academic health literacy team at the University of Sydney, our Sydney Health Literacy Lab, and we came together with health professionals and patients and consumers within the public health system in New South Wales to address health literacy. And we developed a translational research partnership and a point of contact where clinicians, consumers, researchers and patients could come together to address health literacy. And we developed a growing community of practice and capacity building hub where we could address health literacy in an intersectoral way. By bringing health staff, consumers and academics together, we hope that the aim of the hub is to support rigorous research and evaluation activities within the public health system and enable the translation of health literacy evidence into practice. Because we know that a lot of the evidence-based techniques and programs related to health literacy often don't get translated into practice. And so this is what we're trying to kind of support. Hello, sorry. There was just somebody speaking, so please, I didn't quite catch it. If there's something to add, please do let me know. So basically, this is a model of co-creation that informed and drove the early work of the Health Literacy Hub, and you can find it in the paper that I kind of cited at the bottom of this screen. What was really important was that as a university academic team, we came together with the health system to co-create the strategic direction of the hub and to develop shared management systems. And we began by forming a really large community of practice of people who were interested in health literacy. Over the early years of the Health Literacy Hub, we partnered with people within the New South Wales health system to embed and co-create health literacy research together. And that's represented by the circle in the figure. And most recently, we're really pleased to say that this local initiative has been scaled up to a statewide health literacy hub, which has been funded by our Ministry of Health over the next 3 years. And what I want to quickly kind of end my presentation on is talking about what work we have planned and we're currently doing as a statewide health literacy hub, and mapping that against the framework for health literacy systems that was developed by Sorensen and colleagues in 2021. I won't be able to cover off on all 8 action areas of this framework, but I've kind of chosen a few that I think are particularly pertinent to the way that we're scaling up health literacy within the New South Wales system. I wanted to start by focusing on the work we're doing to develop a health literate workforce and health literacy leadership within New South Wales health systems. We're doing this in kind of similar ways, I guess, to many people, but really starting by a seminar series, an online training program, and lots of staff capacity building. And pleased to say that we've reached over 3,900 healthcare providers and consumers through this education, training, and capacity building work that we're leading in the health district. Our seminar series has kind of received really great traction and numbers of people attending from all local health districts. So it's through this kind of research capacity building and health literacy capacity building in the systems that we're able to have really broad reach across the whole state of New South Wales. And we're currently working on developing training and ambassador programs, including a 6-module online training program for New South Wales health staff, covering kind of what we might consider to be health literacy fundamentals. So what's the definition of health literacy? What is the prevalence in Australia? And how can we address this, including in our written communication and our verbal communication? We're also working on a staff health literacy champion program, supporting staff to champion health literacy practices in their services and lead health literacy projects in different areas of the state. In terms of building a health literate organisations, we've developed a patient communication portal, which is an online system and portal that supports all New South Wales health staff to create health literate patient consumer information materials using a 5-step process. This was developed from some earlier work that we have done within New South Wales, and it's been adapted from something called the PIP process, which we've found increased the actionability and understandability of patient information significantly. These are some screenshots of the portal, but it's basically a way in which any information materials developed by New South Wales Health have to be developed through this online system and portal. And so it ensures that all health information across New South Wales will meet the health literacy requirements. A core component of the EPCP is the shell editor, and I really encourage you to use the link on the screen to learn more about the shell editor, which is a unique online tool developed to ensure that health information meets requirements of health literacy, including recommended grade reading levels and recommendations for complex language, as you can see on the screen. I realize I'm running out of time, but I just wanted to sum up by saying The heart of the Health Literacy Hub is that it is a partnership and it is a collaboration between the University of Sydney and the New South Wales health system. And this is fundamental to ensuring that we are identifying, testing, and then scaling up evidence-based health literacy practices across the health system. And by partnering early on, hopefully we can support the scalability of initiatives and can continue to test and implement research across the translational research continuum. We are continuing to work hard to mentor and support clinicians along the way, and really working hard to publish our findings wherever possible. You can learn more about the Health Literacy Hub through our website. So the QR code on screen links directly, and there is the URL at the bottom as well. And I didn't want to miss this opportunity to flag that I am the editor-in-chief of a new journal called Health Literacy and Communication Open. It's a Taylor and Francis journal, and we are currently waiving open access fees until the end of 2024. So please do consider submitting your work to that journal, and hopefully it provides another forum, just like the one we have today, to kind of disseminate health literacy research and practice. I know that was a really quick overview of the work of the Hub. If you'd like to know more, please do reach out to me on the email shown on the screen. But for now, I hope I've stayed within the time limit, and I can now provide a space for our next speaker. Thank you so much.
Thank you, ma'am, for sharing your valuable insights. It's my pleasure to introduce our second speaker, Dr. Reetu, who she did her MPH and PhD from the Department of Community Medicine and School of Public Health at TCMI Chandigarh. Currently serving as a project coordinator for a John Hopkins University founded project titled Reducing the Health Equity Gap for Marginalized Communities in Chandigarh, India, by leveraging key digital health interventions since April 2023. Dr. Reetu has been at the forefront of addressing health disparities in underserved population. During her PhD, Dr. Reetu spent 5 years conducting research on health literacy for the management and control of hypertension in marginalized rural communities. Under the guidance of Professor retired Manmeet Kaur, her implementation of OFIA, optimizing health literacy and access during her PhD, a model used by WHO in national health literacy demonstration projects worldwide, demonstrates her commitment to involve innovative approaches in public health. With previous experience as a district epidemiologist in Amritsar, Punjab, where she oversaw programs such as integrated disease surveillance and H1N1 surveillance, Dr. Reetu has demonstrated her ability to translate research into practical public health interventions. Her extensive background also includes assessing village health sanitation and nutrition committees during her MPH studies and serving as a medical officer in various capacities in both public health and private sectors. Let's warmly welcome Dr. Reetu as our second speaker.
Thank you so much for this elaborative introduction, and not to introduce myself again. But before starting anything, I would like to thank Manipal Health Literacy Unit, especially Dr. Usha, for providing me the opportunity to become a part of this exclusive health literacy webinar series. And I feel it's a great platform to put our views and research perspectives. And we all have one thing in common, that's pure love for health literacy, I must say, and which has been shown here in abundance. So I have worked in assessing health literacy needs and addressing them, especially for marginalized communities. So today I'll be sharing my learnings so far. So first, let me share my screen. I hope this is visible to everyone.
Yes, ma'am, it is visible.
Thank you. So I'll be starting with this. The title of my presentation will be Approaches to Address Health Literacy Needs of Marginalized Communities. So just recently, a few weeks ago, I was presenting in a national conference. Somebody asked me this question after my presentation, that why we researchers always talk about marginalized? Do we have only marginalized population in our country? And what about others? Isn't their health important? Don't they fall sick? So I answered him that, sir, actually, we are waiting for the day when we have enough resources to provide health to all. Until then, those who have been pushed back since centuries, I must say, and even now are not able to generate resources for themselves, they need us. They need priority, right? So we have developed. After that, I'll not be going into how we assess their needs because Dr. Usha has already discussed elaboratively in previous webinar. So there are a number of quantitative tools. They are validated in various populations, right? So it is important to understand why and how some research approaches they are more valuable than others for social and behavior change interventions. So several studies from across the globe, they provide evidence that a well-defined intervention is needed to improve people's health status that we all know. And in public health, we often call our intervention studies as clinical trials or community trials. And there's a hierarchy of study designs for evaluating health outcomes in intervention studies that have placed case control or cohort studies pre-post lower than RCTs, that is randomized control trials. And they have become the gold standard for epidemiologists to carry out intervention studies to test the efficacy of medicines or vaccines. And randomization at the individual level help control the confounder effect that I won't deny, right? But designs like RCTs, though they are used extensively by public health researchers, they have drawbacks in controlling health conditions in real life conditions, as the effect of interventions are rarely sustainable in program conditions, which are affected by many social and behavioral factors. So I'm a new researcher. You may be disagreeing with me. So this is what I have learned so far. So I must say that we all know, this is not new, that many internal and external environmental factors, they affect human behavior, which act as barrier or facilitators to one's health. So effective health outcomes for any condition, especially for the chronic conditions, they are obtained with social and behavioral change. So behavior change in health, it is not a linear but a quantum process where inputs, outputs, they cannot be mathematically processed. So, and chaos theory has explained it very well, which supports the complex interaction of multiple factors on a non-linear path, where small initial changes in factors can produce significant effects on behaviors. So, but most of the intervention methods used by public health researchers, they follow a linear paradigm where the outputs are estimated based on the commencement of treatment or intervention. Now, the outcomes of a study or an intervention are based on several assumptions by those who design the research. But in reality, outcomes of intervention based upon these assumptions are questionable. For the behavior change intervention, researchers should think beyond the worldview of experimental methods and consider another paradigm, which we can call transformative research paradigm, which is needed to bring sustainable changes in health status of people, especially in those who are at the disadvantaged end of society. The power shift, participation, social equality, they all are the concepts that are needed to be brought in fore of any research. So this paradigm has been used in many sciences, especially sociology, but has been rarely practiced in public health. So effective intervention design they should be used in public health with a more, I would say, human approach. So to promote public health, multiple qualitative and quantitative methods are required to assess, design, evaluate intervention in a transformative research paradigm also. For example, to determine the needs of a community or group, researchers need to take the view of participants to gain insight into their culture or planning culturally appropriate and acceptable interventions using mixed method. But I would say only doing mixed method here again is insufficient to achieve transformative research's ultimate goal. So there should be a connection between the researcher and participants, and people need to be at the center of any public health research. An approach within applied research field follows participatory methods for developing and implementing health interventions. So these intervention methods they work as a bridge between the researcher and communities to attain better health. So this study method, became popular among community-based research practitioners, and they used various terminology. Basically, Kurt Lewin, we must all know, he designed this concept. So we call it by many names now, action research, or it's participatory action research, community-based participatory research, etc. And they all come under one paradigm, participatory research paradigm. We can call it that. So ideally, all shades of action research aim to bring social change as the ultimate goal. Now, participatory research that differs from other empirical analytical paradigms used in public health research. And it is based on critical theory, which is way far different than positivism or interpretivism, which is evidence-based and what we have been doing all way back based on all theories we develop. But in critical theory, we aim to improve health and reduce health inequities by involving people, knowing their needs, who are not treated as subjects or objects to be measured by, but are research partners. So it extensively involves participants at every level of research, either from data collection to intervention designing, its implementation, and even assessment. So participatory research provides empowerment, which is an action-oriented concept. And the knowledge is transferred to the communities to strengthen their capacities, actually, using their own local resources. So the opportunities provided by participatory research, it acts as intermediate outcome in reducing health disparities and social exclusion. So I'm talking about marginalized communities mainly. It works there. Now, but for achieving the actual change in behaviors and health status of such people, shift of power to the service users or communities is required. Now, various theories like Arnstein's ladder or its contra-costile services ladders, they've explained the level of community participation. And achieving the higher rungs of these ladders, where people have an equal partnership with delegated power to obtain control in a program or in an intervention, can bring sustainable and effective change in health outcomes. I won't say it's new, it's a new thing, but many places bottom-up approaches have been used and participatory research methods they have been used in lower middle income countries as well for needs assessment, planning health services, primarily for improving maternal child health. And later, it was also used in developed countries like US or Australia among indigenous populations. And even now we see there are many papers coming up with co-designed interventions, but I think some of these studies, I would say, could not justify a good level of community participation in the research or intervention process and have only replicated tokenism. So, I just summarize, I think I'm too early to summarize. So, there are a lot of research is available on intervention, um, but on improving health literacy, but few sustainable methods to bring social and behavior change we find. And mostly public health researchers, they are using RCTs. I won't say they are wrong. They are a gold standard. They will be. But I would say let them be for the clinical trials. Do not, especially for the marginalized where we need to address specific health literacy needs. So let's come up with such approaches of transformative research paradigms. So I think it has potential and it is promising, especially in our countries. We are low middle income countries with less resources. So this can be used. So thank you. I'm ending up early, leaving a more time to discuss. Thank you.
Thank you, ma'am, for sharing your valuable insights on the topic. Now I would like to introduce today's moderator, Dr. Roshan Mahato. He's joining us from Kahan University, Thailand, where he serves as an assistant professor at the Faculty of Public Health with a background in rural health programs. And academia, Dr. Mahato brings an invaluable expertise to our discussion. His focus on health system research and innovative healthcare delivery models will undoubtedly enhance our conversation. Please join me in welcoming Dr. Mahato as a moderator for today's panel discussion. Over to you, sir.
Thank you so much. Good afternoon, honorable speakers, and Mr. Abhinav. Thank you so much for the nice introduction. So yeah, this is Dr. Roshan Mahato. Right now, I'm working as assistant professor in Konkan University. I'm like you mentioned already, so I'm involved in some sort of the health literacy research and mostly the health system research and epidemiology as well. So yeah, very nice to be. It's a very wonderful opportunity for me having as a moderator for this session, and we will have 25 different countries the participants from the 25 different countries. So that is very special. So firstly, I would like to thank the organizing committee for having me as a moderator for this session. And this is very nice topic that we have already discussed about from the listen from the both speakers. So now I would like to open the floor for the question answer discussion session, because we have much more time today, and this is really nice. So the first, I think I will start with the. I'll just take opportunity to ask some questions, starting with Dr. Danielle. Of course, to start with, what are the role of the policymaker playing in the embedding the gap between the health literacy within the health service system? Because this is really great challenges to interlink, right? So can you please explain? Until then, I will ask for the question and answer from the participant as well. Thank you.
Thank you so much. I think it's such an important question. Health policy, I think, plays such an important role. In Australia, we have kind of two really important health policies that underpin our health literacy work and help to provide momentum and support for the work that we do. So we have national standards for which all health systems are accredited against. And that's really important because it underpins the importance of health literacy, because all health services must say that they're meeting these accreditation standards in relation to health literacy. So that's really important. And what's also really important is that in 2024, we have a new national health literacy strategy, which is being developed by the Australian government. And so again, this provides the momentum and for health literacy, and it gives kind of something that we can leverage to say that we need to drive health system changes to address health literacy. So I think health policy is fundamental to underpinning the work that we do in health literacy, particularly at a systems level. So I think it's fundamentally important, and it enables things such as the health literacy hub. So appreciate the question very much.
Thank you so much. So similarly with Dr. Reetu as well, like as you have already mentioned, I am stuck in a very good point, like about the RCT. So, and you have a very good insight on that, like how we can like implement with the clinical research and how we can do the clinical trials and so on to overcome those gaps. So how it will be fit on in the developing countries, how we should start and how we should go to like integrated these things together for the like the developing countries like India or our Southeast Asian countries. What is your ideas on it?
Thank you for the question. In my PhD, I would say it was a trial of doing a participatory action research for addressing health literacy needs of that marginalized communities. And I must say that within that short period of time, we were able to address their needs. And specifically, we found some clusters of population, because then we realized that needs are not common. They do not, even in a village, there was one village, but their needs were different in the groups of population. They were women of middle age. They had different health literacy needs. Young men who were educated had different health literacy needs, and old age people having chronic condition, they had different health literacy needs. Although the resources were provided, the resources the government providing were common, they were getting common resources, but still their needs were different, and they were all lying low on that scale. So then we also realized that how important it becomes to address specific needs. And as researchers, do we really are able to, make interventions for them sitting on our desktops? Even I belong to a clinical background, but my viewpoint was totally changed. That how can I decide beforehand that what do they need and how will I address that? This is what's happening in our cities. Our cities are good for trials, as I already told, for drug trials or vaccination trials. They are very good. There's no other way to do an unbiased research method, right? But here, when we actually want to do health promotion, we actually want to bring health equity, I must say, we have to reach people. to what they need with the resources we can provide them and what they can have on themselves. We will not be there with them every time. If we do a 1 year intervention, what after that? So we need to bring bottom-up approaches, trying to identify what actually are the needs, and then what can be, how can be they addressed with minimal resources. They are not costing to them, which they can sustain after we leave. I think it is possible. It was feasible, and I can say it with a conviction that if that population can do that, that is, I would tell you, there were no roads even to that village. That was like hygienic conditions were that was the least developed village of Chandigarh. Chandigarh is considered as a good, economically well-off city as compared to others. It was a village of Chandigarh. So even if those people can do that, even the government healthcare facilities were not available in the village. People were using other Bengali, you say, the quacks or chemists for their this thing, but they were able to do that. So we can do it is possible, it is feasible. It's just that we need to, move our perspective from being positivist all the time. I must say, we should think critically, being a little realistic. And
Right.
I hope that
Okay,
answered to
Danielle,
your
please.
question.
Yes, that's great. Yes, Danielle, please.
Thank you so
Want
much.
to
And
add
I just
something?
wanted to, I just wanted to add, I think that is a really important point of connection between the presentations today is that what's important is that the research didn't start kind of from an academic, in an academic space. It was really about grounding in communities. And for us, it was the community of the health district, and it was really about working with people in the health system, health service providers and health professionals, as well as patients and consumers, and working together to kind of say, what's the most important thing that we need to start? Where is the most important point that we need to start from, and collaborating and co-designing that from the beginning. And I think it's obviously a very different context in terms of Dr. Reetu's work, but similarly kind of starting with a grounding in the kind of community and with the questions that are important to people. And so I think that was such a nice synergy in our presentations today, and something I wanted to kind of draw out as well. So thank you, Dr. Roshan.
Thank you
I
so much.
totally agree.
So
Thank you, Dr. Danielle.
right. Yeah. So do we have any questions from the audience yet? If not, then I will ask another question from my side because I'm so much curious on both of the presentation. Yes, anyone, please? Not yet. Okay, so I'm really appreciate both of your presentation and insights. So I just want to add something like how might the advancement of the artificial intelligence or machine learning's contribution to improving the health literacy? What will be the idea for this one, and how can we embed this one to the health service system? Because it's really difficult, but nowadays lots of people is practicing for that one as well, like the machine learning or artificial intelligence. So is it okay that, and then maybe we can integrate this one to the digital learning as well, digital health literacy maybe sometime, or how can we integrate these things? Maybe the first you can start with Danielle and Dr. Reetu, of course, because she's working in the very ground level of the developing countries. So it will be a very good idea to discuss, I think.
Thank you. I think it's such a topical question, and there's so much interest in the area of artificial intelligence at the moment. I'm absolutely not an expert in artificial intelligence. I really definitely my colleagues are probably more advanced in their thinking in this space, and really encourage you to read the recent article from Dr. Julie Eyre from our team at the Sydney Health Literacy Lab, who's looked at the work of kind of this, what role artificial intelligence can play. I don't think it's going away. I think it's something that we need to kind of understand, research more, and see how we can leverage the strengths of artificial intelligence to support the work and the end goals of health literacy. We really want to, for example, create information materials that are easy to understand and accessed by people. And AI absolutely can play a role in helping us to do that. But it's kind of working out the sweet spot in terms of how can we work with AI and maximize that, but still bring in the important human element, because we can't, I think, we can't underestimate the importance of that. So for example, in the Shell editor, which is part of the EPCP, which is being rolled out within the Health Literacy Hub, there is and we are integrating artificial intelligence features within that. And so that's a systems-wide response that can absolutely build on the benefits of AI to ensure that patient education materials and information materials meet health literacy standards for all patients in New South Wales. So I think it's something that we need to continue to learn about and from and integrate within our systems that we can kind of benefit from. But of course, we need to ensure that there is an equity lens and that we're ensuring that the way that artificial intelligence is being used is equitable across our health systems and for different groups of patients, and particularly our socially disadvantaged population. So I think that's probably a nice point to hand over to Dr. Reetu to share her experiences and thoughts on that.
That's great. Yes, Dr. Reetu, please.
Okay, I'm also not an expert in artificial intelligence, but for past 1 year, I've been working on digital health interventions, right? So, and those that too with the marginalized community, again with the rural community, which belong to mostly the labor class people. So, what we have observed, we were just trying to find out their awareness and the usability of a medicine app. Dr. Roshan must know about that e-Sanjeevani app.
Yeah.
Right? It's a one and only initiative of such a national government app for telemedicine. Sorry. So what we have observed that if you talk about artificial intelligence, I'm not sure, but yes, digital platforms, they are being used by people, even by such populations, which although are not that educated, that highly educated, we can say, but everybody is using smartphones. We did a survey, 95% were using smartphones with them. And at least one of the member of a household, they knew how to use apps on it. Whether they are using Facebook or WhatsApp, but they are using apps. They know how to download and use it. So I think it's a great platform in future studies. We can use digital media in spreading awareness and reaching out with people. But yeah, but with the population which are like middle-aged or elderly, that I'm not sure, especially in the rural communities, that they are using it. So although it holds a
maybe so it's a matter of accessibility of the device, or what we can say the technology.
Yes, internet even.
Right, internet even. Mostly the internet.
It's not everywhere.
Yeah. That's
India is doing well, that I can say. In our survey, that was very
Yeah, that's good. Okay, Danielle, you want to add something? Oh, so you have muted. You have muted.
Sorry, just one more point to add. So I think it's, again, such an important reminder at this point in the discussion, in that, what's really important is to ensure that the first starting point is thinking about the communities that we want to work with. And, if it's a digital intervention or an AI-informed intervention or something along those lines, the starting point needs to be going back to the community and kind of saying, is this feasible? Is this something that we should be kind of considering and really grounding ourselves in the communities to understand the health literacy kind of strengths and assets and their starting points, particularly in terms of technology and AI-driven kind of research.
That's great, I think, yes. That's how we could maybe integrate those things. So can we have any questions again from participant?
With permission, Dr. Roshan, can I ask one question?
Yes, please, Dr. Roshan, go ahead.
Yeah, so this question is to both speaker, considering a diverse population that you have done the studies among. Professor Danielle is from Australia and Reetu is from India. So, but AI is available at both the countries. And what is happening now, digital devices are always available, and many people, even marginalized population, has an access to digital devices. What do you think? It's a boon or not for the healthcare system, whether it is going to aid to their health literacy, or it might lead to unnecessary over prescription or over diagnosis, giving burden or raising burden to the healthcare professionals. What's your opinion upon it?
Dr. Reetu, I'm happy for you to start if that works. Yeah.
Okay, thank you. Thank you, Dr. Danielle. So, Dr. Usha, you're completely right, as I mentioned earlier, that people are having access to the technology. Smartphones are with everybody, whether it's a laborer or or a vendor. It is with everybody. But as I told, that everybody is not able to access or to do this, technology, especially the people who are middle-aged or are elderly of such populations who are less educated, they are not able to do it. But there is one person, at least their children or somebody, there might be a husband of the lady, they are aware how to use it. So it can be, and as it is available, so it is very promising in India and in other LMICs, of course, to use digital platforms to, raise awareness or to provide health services. But on the other hand, as you said, that is it a burden on healthcare providers? See, I think it's a matter of population here in India. If we talk about India, the population is huge. Service providers are not, there are less, of course. Even the trial we did recently, we used health service providers like ANMs and ASHA, not ASHAs, ANMs and Anganwadi workers to raise awareness to people. But they are so much overburdened already that they are not willing to do future interventions like this because they have got this 6 hours or 8 hours of working and they are already overburdened, overloaded with their work. Even if you provide them such incentives, they are not very willing. So that is a problem, the overburden, or that can be a barrier. But yes, of course, with awareness, if government takes this initiative of, raising awareness of health literacy or training healthcare providers on that, so that's a matter of shifting, our conventional system to health literacy. And as far as I know, we are not still able to include health literacy in our national policy. So it's our duty, it's your duty, Dr. Usha. I know you're working very hard. So we can, do something about that. Thank you.
Right. Danielle, you want to add something?
Thank you. Yeah, I think it's really important for us to acknowledge the digital divide and the differences in people's ability to access and use digital technologies to manage their health and for other things. So I think that's always important to acknowledge. And in addition to that, we know that just kind of hosting something in a digital format doesn't mean that it's meeting health literacy needs and it's meeting kind of health literacy standards. And so, there's lots of research showing that digital health information, is absolutely not meeting those health literacy standards that we need it to make sure that it's accessible to all populations. So I think it's an important reminder. Having said that, there are things that we can do to ensure that health technologies actually do meet those health literacy needs and requirements. And there's a lot of work that we've done at the University of Sydney to address the health literacy in digital ways and using digital means, and also work that I've advised on with the World Health Organization to ensure that health information on the WHO website, for example, that's a very simplistic example of a digital intervention, right? But was designed in a way that met the needs of different populations as well. So I think it's really important. Just it's not a solution if we aren't kind of thinking actively about how digital technology and digital information is responsive to health literacy across different populations as well. I just wanted to add that.
Okay, that's great, I think. So I hope Dr. Usha get her answer already. So yeah, Dr. Usha, you have?
Thank you, Dr. Danielle and Dr. Reetu. I just want to add over here, I see that AI is going to create some trouble for the healthcare providers, because the kind of solution that AI will give, or the differential diagnosis or the differential treatment plan it offers, it rather it doesn't support, but it creates confusion among the patients and the patient's caregiver. And that might bring the concern to we who are, advocating health literacy as one of the essential tool that every individual should have in their hand, and they should, they should be competent to be called as health literate, not just literate. So that's what I just want to sum up. Yeah. Thank you so much for both of you and Dr. Roshan.
Thank you, Dr. Usha. So the last question maybe from my side, because being a researcher, I just want to ask you. Okay, please, Dr. Ritu, you want
Even
to
I
add
have
something?
wanted a question.
Okay.
Yeah, as a
Yeah.
second last question to Dr. Daniel.
Okay.
Dr. Daniel, are you yeah, you're targeting the adult population there, or are there adolescents or children also involved from schools or from colleges?
Yeah, absolutely. I think that's such an important point. So a lot of my research is with adult populations. We do have groups in Australia, particularly from the University of Tasmania, who are really leading the way in terms of research with adolescents and school-aged children, and really kind of doing some innovative work in that space. And I know there's also some work coming out of Germany with Professor Orkan Oken's team as well, looking at adolescents and younger adults in terms of health literacy there. A lot of the work that I do is with adults, and a lot of the work that I do, although I had a systems focus today, but Dr. Reetu, a lot of the work that we do is with socially disadvantaged and culturally and linguistically diverse communities in Australia. So the work of the hub initiated in Western Sydney because it was with in an area that a lot of people didn't speak English, which is obviously the dominant language in Australia, and coming from very, very diverse kind of cultural backgrounds as well. So there was, I think it creates a layer of complexity, but it is the most important kind of communities. They are the most important communities to start with as well. So yeah, I hope that answers your question.
Yes, yes, very well. Thank you. Thank you.
Okay, so we have just maybe we are very much in the last stage. So I'll just wrap up with the last question. So what will be the longitudinal study? What sort of the study we can offer to know about how the health service system can embed it health literacy in a long run? So what may be the maybe we can go with the cohort study or whatever we can offer. So that is maybe just we can explain two minutes each. What is your viewpoint on this?
That's a really great question. I think one of the really important things that we want to do as the Health Literacy Hub expands is get better at data monitoring and monitoring kind of changes in health literacy at a systems level as well. So one of the things that we have kind of at a statewide level, we have data collection systems, which means that we collect data from patients across the New South Wales health system. And so one of the things that we're looking at doing is using those existing monitoring systems to track improvements in health literacy in relation to initiatives such as the Health Literacy Hub. So I think that's really important. Of course, that's not kind of the pinnacle of, RCTs in terms of what we're talking about today in terms of study types, but it's using the existing data to see if we can track changes in health literacy over time, which is kind of a really challenging thing to do at a systems level, but I think it's very, very important to look at existing analytics and existing data that we've got. And of course, that occurs alongside studies which use really rigorous designs and which are really about co-design as well and embedding within the community. So I think it's about leveraging data where we can and how we can, and using different. And I think what was really important about Dr. Reetu's presentation was, using different ways of looking at research questions and systems level questions and grounding those as needed as well. So I think it's, we need to be doing lots of different things at different levels to ensure we're getting kind of a holistic understanding and a really good picture of what's happening in terms of health literacy at different areas.
Okay, that's great. Yes.
Yeah.
Dr.
And I
Reetu?
think one very important point that health literacy should be included in the syllabus or in the schools. It should be inculcated from that very
Right,
age.
right,
That's really
right.
important. We haven't been taught about health literacy since I started my PhD. Only then I would know that what actually we should be literate, but health literate first to actually manage our health on our own. So yeah, a lot of work is to be done in India, I must say. Yes.
Okay, so yeah, it has been a good discussion with all of you. So thank you both of the speaker. Now I'll hand over to the Mr. Abhinav for a final thoughts.
Thank you, everyone. So with that, the panel discussion is concluded, which brings us to the end of this session. It has been such an honor to be a part of wonderful event. On behalf of MHLU, PGI Chandigarh, and the Sydney University, Australia, I would like to extend my heartfelt gratitude to our esteemed speakers, moderators, faculty, staff, and students of MAHE members of MHLU. In the end, I extend my heartfelt thanks to Dr. Asha Kamath, in charge director of Prasanna School of Public Health, Manipal, MAHE, administration of MAHE, press and media, and also all the support we have received. I have not mentioned the name of many, but thanks to everyone of you as you contribute directly and indirectly to the conduction of this webinar. Thank you all.